Ms. Amy Pearce, a licensed clinical social worker, is the clinical director of Glenwood Life Counseling Center, a methadone maintenance clinic in Baltimore, Maryland. Here, she explains how her program participated in the Clinical Trials Network study, Motivational Incentives to Enhance Drug Abuse Recovery, also known as MIDAR. The focus of the study was on abstinence for stimulant use. She discusses the complexity of moving from positive results at the time of the study completion to the adoption of incentives that are less costly and tailored to Glenwood's treatment services.
So the first thing I'm going to talk about is there's a cocaine study that was done. Glenwood was one of the sites, and the NIDA Blending product is based on research outcomes from this study. So I'll tell you what happened in the study. First of all, patients were accepted into this study. There were certain criteria that they had to meet, and then they did an intake interview. And after the intake interview, they were assigned to one of two protocols. So the first one was the abstinence incentive protocol. And if you're interested in looking at the paper and the graphs and stuff that go with the paper, if you go to the ATTC website and look up PAMI, the paper is there under resources. So you can look at that source yourself. So these patients that were assigned to the abstinence incentive procedures, they could draw for prizes every time they produced a drug-negative urine. So the primary target drugs were cocaine, amphetamines, methamphetamines, and alcohol. There was like a bowl or something with plastic chips in it, and each chip was marked with a different prize level. So the majority of the chips, like 42%, said good job. So when a patient got a chip that said good job, it just meant good job. There was no tangible incentive attached to that. About 8% of the chips were labeled small. So small prizes were worth about $1. There were prizes that were on display at the site that patients could see and choose from, different toiletries and small items. There were large prizes. Those were prizes worth about $20. And then there was one chip that was labeled jumbo, and that prize was worth from $80 to $100. So those patients were allowed to draw for those chips. And then the number of draws that they got at each visit was determined by their drug screen results. So the number of draws increased by 1 for each week that they submitted negative samples. So you have 2 samples every week. If those samples were negative, they got a draw. The next week, if they had negative samples, they got 2 draws. So it increased as they increased their period of abstinence. If they missed a group meeting or if they produced a positive urine, the draws reset. So if they had been negative for a length of time and had amassed like 4 draws the previous week, but then they submitted a positive urine, then they would reset to the beginning, okay? So the other thing that happened in that study was that a large prize was awarded when the participant first achieved 2 weeks of abstinence, okay? And patients who were negative for all of the primary target drugs, the stimulants that I talked about before, and alcohol, could earn 2 bonus draws if their sample was negative for opioids as well. Okay, so if they were negative for cocaine, primarily in our population it was cocaine, they were negative for cocaine and all the other target drugs, and they were also negative for opiates, they would get bonus draws. So the maximum incentives available when they did that study, if someone had produced all negative urines all the way through the study, and they were in this group, and they had attended every group that they were to attend, they could get a maximum of $400 in incentives. So that's if everything happened exactly the way we would like it to happen. What actually happened was that people ended up getting about $120 worth of incentives over the 12-week period. So that was the average cost over the 12-week period. So, and then the other group, the control group, the usual care group, attended counseling as was required by the clinic. So depending on their drug use and their length of treatment, they may attend once or twice a week. They were also having the twice-a-week urine screens, but the reinforcement that they were getting was just feedback from the counselor who was presenting with the drug results. So they would say good job if they had a negative urine, and they would talk to them about the drug use if they had a positive urine. So that was the feedback that they got. So what happened as a result of this study was that we doubled the likelihood that the people in the abstinence incentive group would provide negative samples, okay? And then it also doubled the percentage of participants submitting negative samples during the 10 to 12 weeks. So essentially the result was good. People reduced their cocaine use, and they reduced their periods of abstinence. So cocaine use went down, and periods of abstinence were longer. So the incentives were very effective in doing this for them. So what it was like for us at Glenwood doing the study. When the researchers came in, our cocaine use was about 35 to 37%. So staff recognized that this was a problem, that we needed help, whatever help we could get, to start to address it. So the reception was quite positive because of that. The other thing that made the reaction to this study quite positive was that we had research assistants come in and track the incentives and help with the data management and help with handing out the incentives. So we had that additional support, so an additional burden wasn't placed on counselors. And like Pat was saying before, if we ask people to do more things in the same amount of time, it becomes very difficult for them. So counselors, and I just talked to a counselor yesterday who was at Glenwood when this study was being done, and that's one of the things that she said was the support was really helpful, and she was able to remember which patients were able to achieve abstinence, and her impression of the whole study was very positive. And like I said, staff members were able to see results in a relatively short period of time as a result of this. But using incentives that way, we weren't able to sustain that. Part of it was budget driven. $120 for every patient on average over a 12-week period adds up, and when you have a clinic of 550 people, that becomes a difficult thing to sustain. Funding sources are different now. We didn't have the flexibility that we do now at that point in time to decide where our money was going. So that was another concern, was budgeting, not only the amount, but how we were able to manipulate our budget. And the support of incentives for those reasons in the agency was less at that time. So what we have ended up with, what we do now at Glenwood, we do use incentives still. We have a cocaine group that is incentivized. Negative urine screens are incentivized during the course of the 8-week group. We also incentivize attendance at our women's IOP. And we use a tic-tac-toe board to allow patients to track the steps that they need to make in order to earn their first income. So the results of this, our biggest success has been with the women's IOP. So when we started implementing incentives, this was the first week in February. Our billing doubled in the first week that we used incentives. By the end of the first month, it had quadrupled. So the increase in attendance was very large. So that was really effective. The cocaine group, not so much. The drug screens, there's been no significant effect on drug use, cocaine use specifically, after 2 8-week group cycles. And this is probably due to the way that we are implementing them. So again, this goes back to what Pat was saying as well. When staff members are not, they don't have the time to be trained and they don't understand how to implement the incentives, then they don't work the way that we intend them to do. So we need to go back and do some more training on that so that we can increase our effectiveness of that incentive. And we don't have any data about the tic-tac-toe board yet, so no data, sorry. So those are some of the positive effects. We still encounter barriers to implementing these things, and one of the biggest one is staff attitude toward incentives. We still have staff members who complain that we're using incentives, we're paying people to do something they should be doing anyway. There's a lack of understanding of the research. Again, it goes back to education of people, and just the orientation, the mindset that people haven't seen this work for long enough, and for whatever reason they have a bias that we should have to pay people to do these things. So that's an ongoing discussion with staff and helping to educate and helping to kind of address that. One thing that has been helpful is over the period of time that we've been using incentives in IOP, initially there was more resistance. As we've continued to use it, people have not only seen the increase in attendance, but they've seen the effect on individual patients and how they've stabilized and how they've been able to achieve periods of abstinence. And that has helped some staff to change their opinion a little bit. So there's less resistance because they see their patients getting better. So that's one thing that really has helped. The other barrier to implementation of these incentives is budgeting. And again, you know, to do the incentives like the cocaine study would be prohibitively expensive. So we have to figure out ways that provide enough incentives that patients want to do the thing that we're trying to get them to do. Because, you know, one of the things we tried in the cocaine group was using, you know, candy bars. And it didn't work. People, that was not motivating enough for people, kind of obviously. So we have to figure out how to be able to afford those incentives that are valuable enough to people to help them to change their behavior, at least for a short period of time. So that's another challenge for us. The third challenge, again, is just finding the time, setting aside the time, having the materials that we need to provide people with training. Because as we're implementing these incentives, counselors need the training to know how to use them effectively. And that's one of the things that, you know, looking at the blending products seems to be really effective, is providing in one package something that helps people understand how do you target behavior, what things will work, how do you decide what will motivate people to change their behavior, looking at those things based on the research, not just based on what I think is a nice idea. So those are ways that we're trying to implement that in our practice and start to manage those barriers. I'll also just talk for a minute about my experience as a clinician. I participated in my training when I was a clinician at Reach Mobile Health. So I did a one-day workshop on MI and then ongoing training. I did it with Christine.
Everybody does. Everybody does.
Everybody does it with Christine, right, yeah. But one of the things that I found very helpful was the ongoing training and support. So the workshop, you get the basics of MI, the basic techniques, but the ongoing training and support was what helped me to figure out, oh, this isn't working very well. I have questions about this, I'm losing this, I need support to keep this. So that's another thing that if we can figure out how to implement that in our programs, ongoing support for these evidence-based procedures, because what happens, and I'm sure it's different for you all, but in our clinic, things are busy and things are crazy and things are chaotic. And so we have to make sure that we are able to have things that are quick to train, easy to train, and easy to maintain in this sort of really chaotic day-to-day environment. So those have been our experiences, and enjoy the rest of your day.